Welcome to Intake. If you haven't already, why don't you hit the subscribe button and then the notification button, so each time we drop an episode, you will be notified. It's time to shine the light from a mental health perspective. Welcome back to Beneath It All in the African American Community, Episode 3, Part 1. Welcome, ladies.
Hello.
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 Hello. It's good to have you all here. So we have heard from Ms. McKinney and Ms. Hulse in previous episodes, but today we have a special guest here, Dr. Tashina Bernadin. Dr. Bernadin, can you give us a little information on yourself?
Hey, as she mentioned, my name is Tashina Bernadin. I am a family medicine physician here in the Metro Atlanta area. I went to school here in Georgia. I'm originally from Florida, and I graduated from Florida State University with my undergraduate degree. So I am a no. Go Noles.
Great. So one of the reasons for doing this particular episode is to talk about some of the disparities between African Americans and European Americans. And I wanted to do this because, as we know, during this whole pandemic, there was a lot of conversations about the disparities in the African American community. So it's important for us to understand the factors behind it all or beneath it all overall as we look at the community. That's including the medical, the health disparities. I want to start by saying that one thing that I've always known from a historical point is that in the U.S., African Americans have always been perceived as genetically inferior. So I wanted to bring in somebody who could talk to us about the medical aspect, because we have a lot of metabolic conditions among the African American communities. But why do we have them? Like literally, why do we have them? We often talk about historical trauma in the mental health field, which is also connected to these health disparities that are often brought up. So I wanted to talk about the genetic inferior ideas surrounding African Americans. And as we know, historically, this was the justification for slavery as well. But before I do that, I want to give a quote, and I love it because it's from Abraham Lincoln. Abraham Lincoln said, "I'm a firm believer in the people. If given the truth, they can be depended upon to meet any national crisis. The great point is to bring them the real facts." That's the idea. The great point is to bring them the real facts. There are facts behind the health disparities among African Americans, and we need to talk about them. We need to educate those African Americans who will view this series and help them to better understand what it is they're going through and how to address these issues with their healthcare providers, literally. So, Dr. Bernadin, I know you and I talked before. For those of you all who don't know, Dr. Bernadin, as you hear me addressing her, she is also my youngest daughter. And when I spoke with her, she said, "Well, Mommy, I didn't know about this, genetic inferiority among African Americans and Caucasians. I had never heard of that. And I have to be apologetic for her not knowing because, again, I come from a Rastafarian background. She grew up with me that way. Her dad is that way. And so we pushed African history. We pushed emphasizing that they were queens. And so they weren't exposed to the American history. So she didn't know a lot about this. And in a way, because Gina, you talked about it too, that your mother sheltered you. And I realized that I did the same with mine. I sheltered them from this tragic history that African Americans had to go through because I did not want it to interfere with, their esteem of who they were, how they identified as being in the brown skin that they're in. So, Dr. Bernadin, we had this conversation, and I remember calling you and saying, "Oh, did you know that European Americans had more harmful genes than African Americans?" And I thought I was on to something. Like she was going to say, "What?" But she said, "Yes, mommy, I know this." And she started to splurt out this information. And I'm like, "Oh no, we have to talk about this." So Dr. Bernadin, give us some information on the different health disparities between European Americans and African Americans. And if you can, tell us why what's behind these metabolic conditions that we see in the African American community.
No problem. As far as health disparities in the African American community, I think one of the major disparities is, most African Americans in America are poorer than others and usually cannot afford health care, don't seek health care because of fear. So I think those things play a big role into the disparities in treatment. I also feel as though, when you think about Tuskegee and clinical trials that have used African Americans as guinea pigs, I guess you can say, Blacks just don't trust the healthcare system. They don't trust doctors. So they don't seek care. They don't seek advice. They tend to go at the very last minute when things are too detrimental, diabetes out of control, blood pressure's out of control, end up having a stroke or losing their foot. And that's kind of when you'll see them really take things a little bit more seriously. Regarding genetic disorders, I know we had talked prior to about the metabolic disorders like hypertension and diabetes and whether or not they're genetic or if they're environmental or if it's based off of what you eat. And one thing that I have noticed just in my own practice is that I think it's a mixture of both. I think obviously there are some people who can be as skinny as a twig and pretty active and physically fit, but they're still predisposed to hypertension. Both parents had hypertension. No matter what they do, they can't get their blood pressure under control and they need medication. And then I've also seen others where they're morbidly obese. A1C is 14. They're on insulin, on a ton of other diabetic medications. They lose a bulk of the weight, get them back in the normal BMI range, and then their diabetes is gone. So I've seen both ends. I've seen where, diet plays a big role, and I've also seen where it's just a genetic predisposition. So there are different types of genes. You have dominant, recessive, and X-linked. Dominant genes are exactly what they sound like, dominant. They will be expressed no matter what it is. Some examples of that is blood types A and B. Blood types A and B are dominant genes. So no matter what, if you mate with someone who is blood type B and your blood type O, the two are dominant, so your children will have blood type A and B. Most dominant genes are not detrimental. Hence, if they were detrimental, none of us would be alive because dominant genes, as I mentioned, are always expressed. Recessive genes are typically the ones that are detrimental. Those are the ones that you hear about when it comes to genetic disorders. Most of the genetic disorders that you hear about are recessive. And it takes two recessive genes in order for it to be expressed. So if, for example, if you're blood type O, being blood type O is not a detrimental thing. But if you're a blood type O is a recessive gene. So you would have to mate with someone who's blood type O in order for your children to also be blood type O. Or you would have to mate with someone who is a carrier for blood type O in order for your children to be blood type O. Regardless, you need two recessive genes for it to be expressed. Another type of gene is X-linked recessive. X-linked is exactly what it sounds like. It's on the X chromosome. So it will mainly affect males. And the reason why is because males only have one X chromosome, sex chromosome, whereas women have two X chromosomes. So in order for an X-linked recessive gene to be expressed, again, there has to be just one, or it has to dominate. So with women, we have two X's. So whenever there's an X-linked recessive gene, we're not going to express it because we have dominant genes on the other X chromosome. However, we put our children, our boys at risk because we can pass on whatever X-linked recessive gene to the boys. We can pass the gene on to the girls, but the girls will just be carriers. They won't necessarily express the gene. There were some common genetic disorders that I just wanted you guys to be aware of. Like most people know about these disorders, which is cystic fibrosis. It's an autosomal recessive disorder. It typically causes mucus in the lungs and it will interfere with breathing. And it will affect 1 in 25 Caucasians. So it's more prevalent in Caucasians. It'll affect 1 in 46 Hispanics, 1 in 65 African Americans, and 1 in 90 Asians. Spinal muscular atrophy is also another common genetic disorder. Typically, it causes muscle wasting, and most of the time, children don't make it past the age of 2. Fabry's disease is an X-linked disorder, so it will mostly affect men because, again, like I mentioned, it's going to be on that X chromosome. Other genetic disorders that are more prevalent in African Americans and Asians, they kind of group those together. Those are typically blood disorders. Those are the ones that you'll find that are more common in African Americans and Asians, such as sickle cell anemia. Many of you all have heard of that. That's a recessive trait, or autosomal recessive disorder. And it basically affects the red blood cells, cause sickling, and the sickling of the red blood cells can clog the arteries and the arterioles, and basically causes pain. You're not able to transport oxygen to your tissues, and that's why a lot of people who have sickle cell anemia will have pain crises. Another common genetic disorder in African Americans and Asians are beta thalassemia, which again is another blood disorder. It basically causes impairment in the production of hemoglobin in the blood. And hemoglobin is what is used to transport oxygen. So when you are having some impairment in hemoglobin, you're again not getting oxygen to your cells and to your tissues. Now, regards to common disorders in Europeans, which will include Ashkenazi Jews, Middle Eastern, and North Africans. It is a long list. And I mean, I don't know I couldn't tell you why they have so many genetic disorders, but there are more genetic disorders that you will see in the European population. Some are Tay-Sachs, which will typically affect Irish and British descent. And Tay-Sachs causes an inability to metabolize fats and leading to fat accumulation. And again, when you have a lot of fat accumulation, it destroys brain cells and nerves. And typically, again, children don't make it past childhood years, so they will pass before they even reach adulthood. Niemann-Pick is another common genetic disorder in Europeans. It's a neurodegenerative disorder, so it affects the brain function, and typically, again, death is by 2-3 years of age. Wilson's disease, it's not as detrimental, but it is a recessive disorder that you will see most commonly in Europeans. And it causes the inability to process copper, which will cause buildup of copper and which will affect your liver and end up resulting in liver failure. Another recessive disorder is polycystic kidney disease. And it's exactly what it sounds like. It's a bunch of cysts on the kidneys, and it will ultimately leads to kidney failure. Alport's is another one, causes blood in the urine and eventually leads to renal failure. Fanconi syndrome, it's another genetic disorder, causes short stature, causes bone marrow failure, predisposition to leukemia, and death in early childhood. Galactosemia is another genetic disorder. It's more metabolic disorder, but it is a recessive disorder, and it's an inability to process the sugar galactose. So that can lead to liver damage, delayed development in childhood. Ultimately, treatment is a lactose-free diet, but it's not one of the detrimental conditions, but it is one of the common ones in Europeans. Ehlers-Danlos, which is a connective tissue disorder, it's basically where the skin is very elastic. And that's a recessive disorder as well. They end up getting a lot of issues later in life. But most people don't die from Ehlers-Danlos, but it does cause a lot of issues with any connective tissue, including the skin, anything under the skin, nails, things like that.
Dr. Bernadin, actually this morning, because my brain is always going, and I wanted to research articles on, racism or racial biases, should I say, within the healthcare field. I got up this morning and I went to go into the research library at my old university, and I stumbled upon this article from the National Institute of Health, which was done in 2019. And what they found is that darker skin tone individuals, African Americans, as they suggested, are associated with a greater likelihood of having been diagnosed with hypertension. So they wanted to research the whole colorism and the racial disparities in the helping field, that is, the medical field. They reported that they found support for enduring evidence of color biases. They reported, however, that their data could not determine whether the findings could be a function of inter- or intra-racial processes, nor could they definitively rule out a more complex ruling that did not directly involve discrimination. They also offered additional evidence that the results are not likely to be entirely items associated with one or more genetic or historical facts associated with skin tone and hypertension. So at the end, this is what they said. These findings provide yet more evidence that skin color should be considered as a relevant factor, independent of racial or ethnic affiliations alone, and particularly in an increasingly multiracial society, in reproducing harmful inequalities in health and well-being. So what they were saying is that they really found that a lot of people who had darker skin, doctors associated that with them being at a higher risk for hypertension. And the article continued to talk about how after civil rights movement, a lot of African Americans moved to the north. But the Southern African Americans decided to stay in the South, so there wasn't any more mixed racing, as they said, mixed racing in the South, which means African Americans became darker, which also affected their health and caused this, hypertension. So it shows that there is colorism also in the medical field. And we also have racial biases based on, and you and I talked about this, based on, I think, learned behavior, simply learned behavior, how Caucasians are taught to foresee African Americans, because we know that the belief system is pretty hard to break. And so a study on dealing with these racial biases, and I want to make sure I get the name right, it's called More Than Just Tuskegee, Understanding Mistrust About Research Participation. And in this, they found that there were a lot of racial biases from non-medical students up to first year, second year, and then fourth year and residency. There were some racial biases. Some of the numbers decreased by the time these medical students, Caucasian medical students, got to their residency. But there were still some biases that exist. Biases like African Americans have thicker skin, they have stronger bone density. They talked about African Americans being mistreated regarding pain, that these people didn't see, these medical students didn't foresee African Americans' pain as being significant or equal to their white counterparts. And so they were not treated for their pain the same way that whites were treated for their pain. And this is because of the racial biases.
According to the Association of American Medical Colleges, 40% of first and second year medical students have false beliefs about African American skin being thicker than whites. They believe African Americans' nerve endings are less sensitive than whites, and their blood coagulates much quicker than whites. The article also mentions research of 2019 showing there's a higher probability for many providers to associate African Americans with substance abuse. And they are less likely to identify pain in the faces of African Americans than with whites. Due to these implicit biases, African Americans are 22% less likely to receive adequate treatment for their pain. Albeit many providers have unconscious implicit biases, it is important for providers and medical institutions to provide adequate education and advocate for ending these false beliefs.
So we see that there are a lot of racial biases in the medical field, which I also think contributes, because what it does is it adds on to the fact that, hey, I can't trust you. And so we see that in the medical field. Gina, I know that you work in the medical field, and that's one of your things. As a licensed social worker, helping doctors to understand how to really interact with people of color, African Americans. Let's talk about that.
Well, currently I work in a hospital as a strategic planner. So I work in that department, and the goal is healthcare transformation. And we are addressing the items that you are outlining right now, especially in New York. So the idea is that the Center for Medicaid Services wants to be able to stop rescuing, if you will, safety net hospitals from financial bankruptcy, because they are, many safety net hospitals that serve people of color that are vulnerable, vulnerable populations absolutely need support, because the cost of care Medicaid does not cover. So a Medicaid charge doesn't really doesn't cover the cost of care. So I've been in healthcare for about 28 years, and it was a period of time, it was around 2005, all the way up to 2000 and probably 15, probably a little earlier than that. I worked directly with family medicine residents for about 7 years. It was an incredible experience, and I was grateful that I was asked to do it. See, I was an administrator for grant programs that supported people of color, mainly for HIV and other health disparities such as asthma and diabetes, and provided programs that supported people in care that address the social determinants of health, those factors that exacerbate health and healthcare. So during that period of time, I was asked to be the behavioral scientist for the family medicine department. And I had to develop my own curriculum, which was great. And I was able to speak with and teach residents, also be able to view their interactions with patients in a real live medical session. So we had one-way mirrors where I sat, I was on the opposite side and viewed. Patient, of course, consented. And there are times I sat in the room with the patient and the provider with consent. One experience I had was a male patient who was, according to, and they weren't European doctors, they were actually Middle Eastern, but they had implicit biases, and that's what it's really called, is that they had these implicit biases about people of color. And what happens in safety net hospitals, where the majority of the patients are people of color, you may have, you'll have an influx of residents that don't know a lot about the patient population. And because of what they heard, because of what they read in their medical journals, as well as what they've read or how they've been influenced by the media, they come into the session sometimes with these implicit biases. So in this particular session, the patient wasn't feeling well. He wasn't, and my goal in being in that room is to be silent, just to observe the interaction. But I had to ask permission to interject because the conversation was going awry. It was just, he was getting more agitated, and it was two of them, were accusing him of being upset, of being agitated. What's your problem? I'm trying to get to the bottom of what's going on and what's going on with you. You're not hearing me. And all he said was, I don't feel well, and I don't want to have this kind of conversation right now. I have to get to work. I have a lot going on. I came to get my routine visit, to get my medication, my checkup, and I want to leave. I really don't want to go through this exploration that you're doing. And they said, but we need to know what's going on with you, sir. And I asked to interject, and I affirmed what he said using motivational interviewing. So it's a technique that doctors can use, and it's a technique that I teach them and taught them then. I said, I hear you're saying you're not feeling well. So tell me what's going on with you. He said, I come in here every day, and I am a compliant patient. I do what I'm supposed to do. And today I just don't feel well, and I don't understand why they're not listening to me. And I said, well, my goal is to try and help see if we can make some connection here. So tell what is going on. He said, I really just don't feel well. I don't know what it is. I don't feel good. And I said, so tell me what you would like to happen today. And he said, well, I just wanted to get A, B, C, D done, and then I'll be on my way, and I'll reschedule for next week where I think I might be in a better position to have this conversation. And the physician, who was a PGY2, which is a second-year resident, said, oh, okay, I didn't understand. You just seemed so upset. And I needed, at that moment, I said, part of it is that you weren't listening. You made a decision that the patient was angry and upset. And this universal idea that a patient of color is always upset is problematic in the therapeutic relationship, because people can be tired, people can be indignant, people can just be frustrated, but you take it, you internalize it, or because that is just what you've been conditioned to believe, is that this person is just an angry person, and that's not the case. And it's unfair to the patient. They don't get the care that they need. They're not heard, and then your care isn't individualized. It is this idea that this is just how we treat this group of people, and you're doing yourself a disservice as a clinician to really learn how to work with people, and improve your skill as a physician when you really understand that the person sitting in front of you is unique and has unique experiences. So yes, I developed curriculums, and I went all the way back to, and you know, I would say I believe in Carl Rogers' 19 propositions is one of the key things that helped me. And the reason why it helped me is because, in terms of teaching and using this as a tool with physicians, is because I needed physicians to understand a person that they're treating uninfluenced by anything in the world. That when we come into the world, we're like this one little, you know, single cell organism in a dish. And it is the experiences that we have going forward that influences the way we see ourselves and influences the way that you see us. So if that's the case, you have to be very mindful of how you think, very mindful of how you feel. So much so that if you really think you can't be a service, then you really want to think about which population you want to really work with when you complete your residency program. And there's no judgment here, but these are things that you are responsible to do, is to really take a deep internal look, to be able to say to yourself, do I have implicit biases? And if I do, what do I need to begin addressing that? Do I, is it, you know, is my automatic thought when it comes to pain? Yes, I've been taught in the books and by people that African Americans have, you know, can tolerate pain, but do I have a bias because the person also has a substance use problem? Because people with substance use problems still have pain and still need to be treated. And if a person has sickle cell, I've seen a number of patients with sickle cell, they will not treat. They just will not treat. And African Americans in particular and Hispanics come into emergency rooms more. And this is why, you know, the whole, you know, Medicaid redesign team, this whole reform to shift the way the healthcare system is, where doctors are now responsible for the care of their patient, where they need to do it at reduced costs, but they need to improve healthcare, right? And they need to do it where the healthcare needs to occur. So you need to figure out how to draw your patients into your primary care practice so they can avoid emergency rooms, so they can avoid, you know, urgent care centers unless they absolutely need it. But the reason why patients wait is because, one, there is literature, and I'm looking at the Institute for Healthcare Improvement. There's literature that supports the fact that even with African Americans, there are greater wait times than our European counterparts. So there's a disparity across the continuum, and there's a lot of work that needs to be done to be able to begin addressing that. Now in New York, and this happens in other states as well, they have DSRIP. And I don't know if anyone is familiar with the term DSRIP. That is the Design System Reform Incentive Payment Program. And basically it was an $8 billion reallocation of funds from CMS, from the Center of Medicaid Services, to put back into the healthcare system so that you can do those three things: improve healthcare outcomes, reduce costs, and have it happen where it needs to happen. So one of the key things that they poured money into was the social determinants of health and creating programs and projects that addressed it. So giving people, and when you're interacting with patients, that you're giving them the opportunity to speak to what are the other factors that may be associated with poor health outcomes, and we're addressing them. So we're looking at, does the person have a refrigerator? Where does the person live? Is there mental health or substance use, other, you know, cofactor that is existing with the patient? Who are their support systems? Do they have money? Do they have insurance? All these factors play a role in whether or not a patient will have a successful outcome. These are issues that providers, I can tell you in my experience, were not looking at, did not pay attention to, did not care about, and yes, would treat patients according to the way they look and not according to what their condition was displaying. And I've seen change. I have a unique experience where I've had PGY1s until graduation. So I did see changes in their perspective, in the way that they thought. And I gave them a platform to be honest, because no one in those cohorts were Black like me. They were not African Americans. If they were a person of color, they were from another country.
For more than 100 years, African American physicians were excluded from the American Medical Association, including some state and local medical societies. As early as 2008, the American Medical Association provided an apology letter to the National Medical Association regarding their reinforcement or passive acceptance of racial inequalities and exclusion of African American doctors.
They did not bring on, they did not accept students that were African American. And they had their reasons, of course. And they had their justification for why they did that. And
because Blacks have lower test scores, that's why.
Say that again, please.
Because Blacks have lower test scores.
That is exactly why they did it. They wanted to have a higher average overall, and African American students tend to score lower. So instead of saying, let us prepare our students better, the decision was to not accept students that were African American. And there was one that was Hispanic from the neighborhood, which I was very surprised. And he did quite well, but he didn't stay within the community. He moved to another state once he graduated. And he was very frustrated by what he had seen and experienced. So this is exactly, where we are today, and the fight continues. So there was, again, $8 billion spent in DSRIP. DSRIP actually ended this year. It was a 5-year waiver program. And they have seen, and the idea was that you reduce unavoidable ED visits and inpatient stays by 25%. They did achieve that goal. They did. But did they really eliminate the mistrust? Because one of the key things that happened is that all of the supportive staff that were trained to do so, social workers, case managers, are the ones who are equipped to have those conversations. The folks who don't, or who are still not equipped to have it, is the physician, him or herself. So that's the work that still needs to be done.
Yeah, I agree. Obviously, I'm a recent graduate from residency, and that whole behavioral health aspect and implicit bias and training how to do motivational interviewing, I feel like that's relatively new in the medical field. It's not something that was taught to a lot of older docs. So there's still a lot of implicit biases, and it's unfortunate because you will, I work with had white counterparts, people from different countries. And I think media plays a huge, huge role in what people think of African Americans. They look at us as loud. They look at us as drug seeking. They look at us as being poor, not having education. So it's those implicit biases that are, put off on people, why they don't treat them a certain way. And I think it's important that every residency program has someone like you, Gina, because otherwise they won't know, and they'll end up going out into the real world, continuing to have their implicit biases, or not even realizing that I can't break this, so I shouldn't even focus on treating this population. As far as wait times in the waiting rooms, I had no clue about African American experiencing more wait times. Had no idea. I do see a lot of African American pain not being treated well, and that is because of the stigma of them being drug seeking, as well as that, it's not real. The reasons why you would see such high mortality rates in African American women with just delivery. And it's, something we've come so far with, delivering babies. We've been doing this for centuries, but yet African American women are still dying at a higher rate than our counterparts. And a big part of that is because whatever they're voicing or vocalizing is not being taken seriously. So I think that is something, like you said, that we still really have to work on. I think it is important. I'm not by any means trying to promote segregation, but I think it's very important when you seek care from someone who looks like you. It makes you feel a little bit more comfortable in knowing that, okay, well, this person looks like me, so they would understand where I'm coming from. So I think that's important for anyone.
It's an important option and should always be available. If you're working in an area where you have vulnerable populations, folks who are poor, their social economic disadvantages, it's fair to assume that people probably will not have had the opportunity to have advanced education. And one of the key things that I have recognized with people of color is that sometimes it's very hard to communicate what you feel. So you will communicate it the way you know best. And it might involve expletives. It might involve, being loud. Because when someone doesn't hear you, or when you're speaking to someone who's deaf, what do you typically do? You speak loud. Because you think that louder means that they'll hear you. And it's really about people not just hearing your loud voice, but really understanding, really listening to what it is that you're trying to communicate. And understanding that you may say things differently than they do. And these all come out in implicit biases, and people of color can be embarrassed about things in their lives. They don't like talking about things or failures that they've had, or knowing that someone will judge them. It's very difficult to make a person of color feel comfortable to talk about things that society says is just not good. Whether it's sexual activity, whether it's HIV infection, whether it's using substances, whether it's domestic violence. People need to be able to speak freely and openly and not feel that they're going to be judged. And yes, that implicit bias does extend to judgment.
If you're a professional who would like to be on the show, or an individual who has struggled with mental health and would like to be a guest, email us at info@intake.tv.
Follow us on all of our social media platforms.
If you'd like to learn more about Intake or our guests, visit our website at intake.tv. Join the conversation by making a comment below.